Welcome to a special edition of Derm Drop created specifically for primary care providers, entitled Navigating the Biologic Frontier, How PCPs Can Become Patients' Heroes by Partnering with Derm. And it's not hyperbole. You can become your patient's hero when we work together to help them feel better. And that's the magic of medicine, is helping patients feel better. So what are our objectives today? They are primarily to help you understand the basics of biologics, to increase your comfort level with biologics, providing guidelines for referral, how do patients and providers benefit from biologics, talking points for patients, and what to know when co-managing with your dermatology colleagues. I do have some disclosures for this presentation, as I am or have been a speaker or advisory board participant for the following biologic manufacturers: Sanofi, Regeneron, UCB, Galderma, and Leo. So what are biologics? Well, they're monoclonal antibodies, in other words, engineered proteins that are made from living cells, hence the name biologic. They're usually refrigerated, and they're injected either subcutaneously, in most cases, or in some cases, intravenously. They block cytokines. Cytokines are circulating inflammatory proteins, for example, tumor necrosis factor alpha or TNF alpha, interleukin 4 or IL-4, interleukin 13, interleukin 17, and interleukin 23. These are the primary cytokines involved in the dermatology diseases for which we currently have biologics. They block these cytokines by binding to them or their receptors on cell surfaces and thereby preventing them from working. How many biologics are there in dermatology? Well, depending on how you count, there are at least 15, so quite a few. And what dermatology conditions do they treat? Well, they treat psoriasis. In fact, that's the condition for which we have the most biologics. They also treat atopic dermatitis, aka eczema. They treat prurigo nodularis, hidradenitis suppurativa, chronic spontaneous urticaria, otherwise known as hives, and bullous pemphigoid. And there are many more in the pipeline. So how do biologics differ from quote-unquote small molecules? Well, small molecules are synthesized chemicals. They're usually pills or topicals. They enter cells and alter pathways inside of them. In fact, most traditional medications are technically small molecules. For example, prednisone and triamcinolone, which are also commonly used in dermatology. But the term small molecule is generally reserved for newer, more targeted mechanisms of action. These are JAK inhibitors, for example, Rinvoq, Cibinqo, Litfulo, and Olumiant, which are small molecules that are commonly used in dermatology. There are also TYK2 inhibitors, specifically Sotyktu in the dermatology space, and phosphodiesterase 4 inhibitors, for example, Otezla. How do biologics differ from traditional treatments? Well, they have better efficacy. In fact, many patients get clear or almost clear on biologics. They're also faster in many cases. Even severe patients can get 50% better in as little as 2 weeks. And they're safer because they're highly targeted. So how safe are they? Well, they're very safe, especially compared to other systemic options. For example, Dupixent. This is commonly used for atopic dermatitis. In fact, it's one of the most common biologics prescribed worldwide. And its most common adverse effect is conjunctivitis, which is only about 10% higher than placebo. The way I describe this to patients is you might get a little bit of dry eye. If it's more than that, let me know. Even if it is just that, I can help you manage that dry eye with supplements, drops, wetting gels, etc. So not a big deal. Another example is Skyrizi. This is a commonly used biologic for psoriasis. Through this mechanism of action, which is the IL-23 pathway, adverse events are very rare, in fact. And when they do occur, they're usually just nuisances. For example, headache or fatigue for maybe a day or two following injection, but even those are very rare. So aren't these immunosuppressive? That's what you've heard, right? Well, no, they're not broadly immunosuppressive like prednisone is. Prednisone knocks out almost the entire immune system, or cyclosporine, which has been traditionally used in dermatology and that is used less and less as we have these biologics, which are much safer. So, yes, these old medications are immunosuppressive, but these new medications are not because they're more targeted. These are considered immunomodulatory agents, and I like to give patients a mixing board analogy. I'll tell them, the big giant mixing consoles in a recording studio with thousands of buttons, knobs, and levers. Well, that's what your immune system is like, and you've got one or two of those that are turned way up, and so they're disproportionate in the mix. They're creating a little bit of noise, and these medications go in and turn down those two knobs to make them normal, to balance them with the rest of the immune system, to restore harmony and make your immune system work well together like it's supposed to. So when you use that kind of language that includes restoring, normalizing, balancing, and harmonizing, which are very accurate terms, we help patients feel comfortable about these medications, which can be not only life altering, but can slow down or even stop disease progression, which in many cases can become debilitating. I'll give you another example. Specifically, I have a patient on an IL-23 inhibitor for psoriasis. He has HIV, and we have him on this immunomodulatory biologic with the blessing of his infectious disease provider, and he's had no complications. So that should give you a little bit of comfort level. What about boxed warnings? Well, TNF alpha inhibitors do have a boxed warning for serious infections, malignancy such as lymphoma, and non melanoma skin cancer. But there's mixed data on these things, and it kind of depends on whether you're looking at randomized controlled trials versus cohort studies. Um, it's important to put these into context. We have these conversations with our patients so that they can contextualize the risk of their disease and the relatively low risk of these potential complications. TNF alpha inhibitors are a little more immunosuppressive than the other biologics that we're using these days, so they're used less often, but they are still used. So it's important to acknowledge that. Siliq, which is an IL-17 inhibitor used for psoriasis, its generic name is brodalumab, does also have a boxed warning for suicidal ideation and behavior. This is kind of controversial due to the elevated background risk of suicidal ideation and behavior in this population. This medication requires a REMS program, and as a result, and because we have so many other options, it's uncommonly prescribed. So, not one that your patients are likely to get if you refer them to dermatology. But all of the other dermatology biologics, including the IL-4 and 13 inhibitors, IL-17 inhibitors, and the IL-23 inhibitors that we've talked about, do not have boxed warnings. So, what about non serious infections? These can be things like upper respiratory infections. This is a warning that you find ubiquitously on almost every package insert for immunomodulatory drugs. And there's a lot of debate about why that is. Upper respiratory tract infections are quite common. And could it be just that when patients' disease is controlled, they're engaging more socially, they're going out, they're feeling less self conscious, they're feeling better, so they're interacting with people more often and therefore exposed to these viruses that are being passed around in these social situations? Hard to tell, even if they're not specifically targeting that portion of the immune system. Anytime you modulate the immune system, there can be a little bit of a seesaw effect as things adjust and settle in and sort of offset each other. But this, again, is a pretty infrequent adverse event. We don't see it very often. When it happens, it's pretty minimal. Fungal infections, especially oral candidiasis, can be seen with IL-17 inhibitors, specifically, or especially, I should say, with IL-17 A and F inhibition, which only occurs with Bimzelx. This is only about 15% of patients. It's very easily treatable, and once it's been treated, it's not typically recurrent. As you know, there's many ways to treat thrush. I tell my patients to just call me so that they're not bothering you, and they don't even need to come in. If they notice the symptoms of thrush, which I review with them, they can call in, and I'll typically go straight to about a week of oral fluconazole just to be sure I knock it out. If you prefer oral nystatin or one of the other options, clotrimazole troches, whatever your preference is, this is an easy thing to treat and doesn't typically come back, but every patient's different. Again, this is mostly applicable to one particular biologic. Are there any other concerns with biologics? Well, there is a potential or theoretical concern for inflammatory bowel disease in IL-17 blockers. These are used for psoriasis and hidradenitis suppurativa. In pooled clinical trials, they found no risk of inflammatory bowel disease. There have been case reports, and the role of IL-17 in the gut suggests a possible risk, so it's still sort of controversial, but nonetheless, we avoid IL-17s in this population. That's easy to do because there's always another option available for those patients. Again, suicidal ideation and behavior and IL-17s. This is inconsistent across the class. We mentioned brodalumab, trade name Siliq. There's been some signals in other products in this class, including Bimzelx. And in many cases, we've seen that this is in line with higher population rates or higher rates within this population, meaning patients with these diseases, especially those like hidradenitis suppurativa or HS, which can have significant morbidity and can be very painful, malodorous, just very debilitating. These patients often have a higher rate of suicidal ideation and behavior anyway. So is it the medication that's causing it, or is it the underlying disease that's causing it? Tough to say, but again, we can select other mechanisms of action within this population. You may have noticed that both of those concerns occurred in the IL-17 class. So why use IL-17s at all? Well, they are the fastest psoriasis biologics, and they have the best psoriatic arthritis data. So if I have a patient who is absolutely miserable, needs to get better right away, just to stop their suffering, or because their daughter's getting married in a month, or just so that they won't give up on a biologic because I know how much it can help them, I'm going to give them an IL-17 because, well, as long as there's no contraindications, because the IL-17 will work the fastest. And as mentioned earlier, this is the class that can provide as much as 50% improvement in as little as 2 weeks. And this includes patients with thick, giant plaques all over their body. The improvement is dramatic. It's fun to see, and the patients love you. That's the kind of hero things that we talked about at the beginning of the presentation. And when I have a patient with psoriatic arthritis, that can be very painful, can be very, very difficult to treat. And so I'm going to make sure I'm using the best medication available. So when do we avoid or switch away from IL-17s? Well, as mentioned, if the patient already has inflammatory bowel disease or suicidal ideation or behavior, that's not the class we're going to select. Or if one of those things develop during treatment, then of course we'll change them to another agent. So what about minor side effects? We've talked about some of these, but injection site reactions are commonly cited. They're not commonly experienced, but we do see it occasionally, and these consist of mild erythema or swelling at the injection site. These are typically self-limited. They might last a day or two. They're not that bothersome, and they're preventable in most cases with an H1 antihistamine. So I'll tell my patients to take fexofenadine on the day of their injection, the day after, and that usually fixes it. So again, not a big deal. Are there any rare side effects? Of course, there are. What doesn't have rare side effects? Everything does. But I'll give you a couple of examples. So, Dupixent, for example, can cause joint pain or red face. I do mention to my patient that there are these potential extremely rare side effects and not to worry about them. They're unlikely to have them, but if anything unusual happens at all, to let me know. So, are labs required? Well, TB screening is required for TNF alpha inhibitors as well as other psoriasis biologics. These are included in the labeling of all psoriasis and HS biologics. Um, this is largely because TNF alpha inhibitors have been reported to reactivate tuberculosis. And since those were the first biologics in the space, that warning has carried over into other biologics for those diseases, even though we don't think that their mechanism of action is implicated in the pathogenesis or reactivation of tuberculosis. So that's there. And because we're testing for that infection, which might be latent and patients might not know they have, it is also customary to test for other potentially latent and undiagnosed infections, hepatitis B and C being the primary ones in that category. So, again, in the psoriasis and HS biologic space, we're typically screening before patients start for tuberculosis and hepatitis B and C. And while we're at it, we often get a CBC and a CMP and monitor that every 6 months is what is typically done. It's extremely rare for us to see laboratory abnormalities. They're typically transient, but when they do occur, they're typically rare, mild neutropenia or LFT elevations. Again, we typically just recheck, and if they maintain consistent elevation, especially if they didn't have uh, any baseline elevation, which we do get before starting these medications, and they don't have fatty liver disease, for example, or other comorbidities that might account for that, alcohol consumption, excessive Tylenol consumption, for example, then again, we just switch classes. And that's very uncommon, but it's an easy thing to do. Labs are not required for IL-4 and 13 inhibitors, the combination, which is Dupixent, IL-13 inhibitors, of which we have two, Adbry and which is tralokinumab, and Ebglyss, which is lebrikizumab, or IL-31 inhibitors, which we have one of, which is nemolizumab, trade name Nemluvio. So the biologics in that space, which is eczema and prurigo nodularis, as well as urticaria and bullous pemphigoid, do not require any labs, so they're easy. So what about drug interactions? There are none at all, ever. It's easy. Why? It's because they're injected biologic proteins. They're not metabolized by the liver or the kidneys. They're broken down by catabolic enzymes the way other antibodies naturally produced by our body are broken down. They're also not substrates, inhibitors, or inducers of CYP enzymes. So it's easy. Patients often ask about that. They're concerned about polypharmacy, and you can set their mind at ease that they don't have to worry about this being another potential interaction with other medications. So, what about vaccines? Well, there's the official guidance, which is to get age appropriate vaccines prior to starting and to avoid live vaccines. This is pretty much across the board. But there's also the practical guidance. Studies show the biologics do not blunt antibody response. That means you can be on a biologic, get the vaccine, and it will work just as well as it otherwise would. And also, live vaccines have been given without resulting infection. There was the example of the Dupixent trials that were being carried out in Brazil when there was a yellow fever outbreak. The vaccine for yellow fever is a live vaccine, and it was given to those study participants. None of them had complications, and they all had normal antibody responses. So we do have evidence that even live vaccines are not a problem in this population. What about pregnancy? Well, we do have a biologic in the TNF space called Cimzia that has been studied in pregnancy and deemed safe for those patients and for the developing fetus. That's because there's no FC region on the antibody, which is necessary for transport across the placenta in order to reach the baby. For other medications which have not been explicitly studied in pregnant patients, you just have to evaluate the individual risk benefit ratio. For example, we had recent statements from the American College of Gynecology, the American Association or Academy of Dermatology, and the European Task Force for Atopic Dermatitis, stating that Dupixent can be considered for pregnant patients. And there's even verbiage in the Dupixent PI stating that the health of the mother in relationship to the health of the child must be considered. In other words, healthy mothers make healthy babies. So if your patient is otherwise pretty mild and might be not miserable and okay controlled in topical medications during their pregnancy, then maybe we forego it just to put everybody's minds at ease. But if they're typically very severe, very miserable, that's going to put an extra toll, an extra burden on their bodies that will take away from their ability, their body's ability to support that developing fetus. So keep that in mind. What about lactation? Same advice applies. There's data lacking in this area, but it's considered low risk. And if you think about it, these are proteins and they're meant to be injected and absorbed into the bloodstream and the tissues that way. They will not typically pass through undigested through the GI tract. So if they're being ingested by a baby, they're expected to be destroyed by the digestive system and not reach the circulatory system. But even if they do, they're not expected to be harmful. So, they're again, what are the benefits of breastfeeding? Do they outweigh those of the mother's need for control of their disease to be an effective mother and to get the sleep that they need? Because remember, eczema keeps patients up. That's what Dupixent treats. So these patients and their babies may be better off if they're treated. But again, you decide that on a case-by-case basis, and that may be not true for each individual scenario. You also got to remember that biologics avoid the risks of other medications. For example, corticosteroids. With topical corticosteroids, you run the risk of atrophy or skin thinning. You also have risks of dyspigmentation, which can be lighter skin in many cases, or pinker skin due to telangiectasias. And there is also the potential of topical steroid withdrawal. This is still somewhat of a controversial entity, but we're getting more and more clinicians that are acknowledging this complaint from our patients, a select number, a tiny number, and there's even beginning to be a body of research supporting that entity. And so even though it's rare, we can potentially avoid that, which is not a comfortable thing and certainly a win if that can be avoided. Even more importantly, we want to avoid oral corticosteroids. They cause gastrointestinal bleeding in some patients. They can cause avascular necrosis, osteopenia, and of course, hyperglycemia. So they may not even be appropriate for a subset of our patients. Biologics also allow us to avoid the risks of DMARDs. DMARDs are disease-modifying anti-rheumatic drugs, and these are the old school pills used in rheumatology and dermatology still, but less than we have in the past because of biologics and small molecules. But they're the class of medications that people are scared of because they are immunosuppressive, broadly immunosuppressive, and they come with a wide array of potential side effects, many of which are much more serious than we would see in the biologics that we've discussed. Examples of these medications include methotrexate, cyclosporine, mycophenolate mofetil, and azathioprine. The risks of these medications include malignancy, infection, hepatotoxicity, nephrotoxicity, pulmonary toxicity, birth defects, pancytopenia, hypertension, and hyperlipidemia. So the relative safety of biologics should provide both providers and patients with a high degree of comfort. So when should you, as a primary care provider, refer? Well, when the disease is severe, but I think that's obvious, and I'm sure you already do that. But you can also refer patients who are mild to moderate if they're not controlled on the medications that you've prescribed, if they're getting side effects from the medications that they're already on, if the outward disease might be mild to moderate, but the quality of life impact is severe or even moderate, and that includes impact on work, school, family, social, and sleep. This can also include lifestyle factors. I always think of a patient of mine who was pretty well controlled with their hand dermatitis. They had eczema localized to the hands. It was severe, but we got it pretty well under control with clobetasol, which is a super potent topical steroid appropriate for the hands, not for the face or intertriginous areas, so keep that in mind, but it is appropriate for the hands. And he cleared pretty well, but he wasn't very happy with the treatment regimen, and that's because he had to constantly put this stuff on. He felt sticky, he didn't want to shake hands, he didn't want to pick up things, he felt like it was getting things messy. So even though he was clear, it didn't meet his lifestyle needs. So we put him on a biologic and he was super happy. And in some cases, just preference. I'll ask patients, what they prefer, and you sometimes get patients that want a shot rather than a topical or a pill because it's less frequent, it's easier, it's better for them to remember, they're more adherent to the treatment regimen. You should also refer patients to dermatology for consideration of biologic therapy if they have systemic symptoms, especially joint pain, which again occurs most frequently in the context of psoriasis. And as we previously alluded to, you might need to get them better fast. They have a wedding, a graduation, or a high school reunion coming up. Biologics are going to be the fastest thing in many cases. I also want you to keep in mind whether or not patients have HS, which is short for hidradenitis suppurativa. This is a condition that is frequently missed in not only primary care and urgent care and emergency departments, but even in dermatology. This is a condition that commonly occurs in the skin folds and other intertriginous areas, but sometimes in ectopic areas as well. But the classic areas include the groin, under the arms, under the breast, sometimes even under that abdominal fold. But I have had cases that occur on the neck and even on the face. So, it's definitely a heterogeneous presentation and distribution. But the classic distribution are these recurrent pus bumps, folliculitis, furuncles, carbuncles, abscess, or quote unquote cysts, and they keep coming and going. If they have had 2 in 6 months or 1 lasting 3 months, then those lesions qualify as HS. And it's important to get an accurate early diagnosis because HS progresses and turns into a very severe, very painful, very smelly, very debilitating disease. And I have had to put patients on disability because they were unable to do their job due to the severity of their HS. And there is a window of opportunity for many of these diseases where if we catch them early and treat them aggressively, we can slow down, stop, or even reverse the course of that serious chronic disease. So don't hesitate to get patients over to us for at least evaluation. Do you have to refer to a physician? As a matter of fact, no. Most biologics are prescribed by APPs. Not always, not in every case, but the practice will certainly get that patient to the appropriate level of care if someone in the office is not comfortable or includes that in their practice. But I'm a nurse practitioner and I write a high volume of biologics, so don't feel like you have to make sure you specify that this needs to be seen by a physician. That's sort of practice dependent. There are still some physicians that keep that under their wing, but that's not the case in every practice. So, how old do patients have to be to get a biologic? Well, it depends on the drug and the disease, but Dupixent, for example, is approved down to 6 months of age. And again, Dupixent is an eczema biologic. It also treats a number of other diseases, asthma, as you may be aware. Um, and those pediatric patients may only need an injection as infrequently as once a month. So, yes, it might be a little bit of a wrestle, a little bit of drama time when the parents go to inject once a month. But we often point out to patients and parents that, um, you know, a minute of pinchiness once a month is worth a whole month of no itchiness. So, kind of a catchy way to remember that. And these kids come in just so much happier than they were on initial presentation. But even for our adult patients, it's important to know that these biologics are safe down to 6 months of age because it helps them feel comfortable with the safety profile of these medications. Speaking of pediatric patients, how do they benefit from biologics? Well, they often get improved sleep, and that applies to both the patient and the family because if the patient sleeps, the family sleeps. There's a better family dynamic. People are less grumpy. They're getting along. Pediatric patients also have improved growth after they've been put on biologics. Patients with severe eczema often don't meet the growth milestones and are kind of off the normal growth charts. And if you uh, get them started on a biologic, they often return to normal growth and obtain normal stature with time. And that's important. Nobody wants short kids. Nobody wants to be short. No offense to you short people out there. I'm one of you. So, you know, but let's do what we can for these kids. And it also improves attention and learning. So this means ADHD that might come from being itchy or uncomfortable, behavior and learning issues because they're self-conscious. This applies obviously to while they're in school, but they also have fewer missed days. So they are in school more often, and when they're there, they're more attentive, they're more tuned in, and less self-conscious, less disruptive, just doing better overall. It also, and this is super important, can stop the atopic march. So patients typically start with atopic dermatitis or skin eczema, of course, and then they progress to food allergies. It's not usually the other way around, as is often believed by parents. They go from the classic scenarios, going from atopic dermatitis to food allergies and then asthma. Food allergies can really make life difficult, both from a convenience and what do we feed the family point of view, but um, also the GI upset that can happen, especially if you're out in public and you accidentally ate something that you're sensitive to or they're sensitive to. And of course, asthma can be debilitating and can prevent patients from participating in sports or performing at the level that they want to perform at. And if you can stop that with a medication like Dupixent that is as safe as it is, that is a win-win, a huge win. So remember that. So even if they're doing okay on topicals, you may not be really getting at the underlying pathomechanism that's driving these other comorbidities such as food allergies and asthma. And of course, speaking of asthma, you often get a twofer. For example, you can treat eczema and their asthma if they already have it. I've got lots of stories where I've given a biologic for one condition and ended up treating another condition the patient didn't know they had, or I didn't know they had. But when I know they have it, then we can select biologics that do treat um, two or even three or more conditions. Examples of these include atopic dermatitis with comorbid chronic hives, sometimes eosinophilic esophagitis where they're having trouble swallowing, chronic rhinosinusitis with nasal polyposis. Um, Sometimes there's also an overlap with prurigo nodularis, this really itchy severe skin conditions. So patients might have one or more of these, and one biologic can knock out several of them. So huge win there. So how do adult patients benefit? Well, they get better control, and in many cases, finally their hope is restored. Some of these patients are just like, oh, I've gotten the same cream every time I go to another provider. It's the same old thing. There's nothing out there for me. This is how I have to live. But you put them on a biologic, and they're like, oh, this is what life can be like, and they're hopeful again, and they suddenly realize that they don't have to live with this. And it means an end to the revolving door of providers. Some of these patients are going, especially in diseases like prurigo nodularis, which is often not well understood, not well diagnosed, and not well treated. They're doctor shopping a little bit because they're just not getting the care they need. And again, they're given the same old cream and they're not getting better. Again, a better safety profile compared to steroids, oral and topical, and compared to the DMARDs. We've touched on that. Better sleep for adults as well. It improves mental health, their productivity, their weight, blood pressure, etc. There's a lot of comorbidities that come in adulthood due to lack of sleep, lack of quality sleep, or disrupted sleep. Biologics can restore that quality of sleep and have a ripple effect on many other comorbidities that they may be dealing with. Also reduces general inflammation, which can reduce the risk of other diseases, including heart disease. Yes, heart disease is an inflammatory disease. And dementia. We have data that biologics can reduce the rate of dementia. So there's a lot of potential benefits here when you treat from the inside and get at the root of the problem rather than just putting a Band-Aid on it, treating from the outside when it's really a systemic disease. It can also avoid, stop, or slow permanent damage. This is particularly the case in psoriatic arthritis where joint damage is occurring. And I tell patients, unlike the skin where we can return the skin to normal, we cannot return the joints to normal. Once the damage is done, that's permanent damage. We can slow down or stop that damage, but we can't reverse it. So we want to get on that early. You need to be aggressive with patients who have joint pain. Also in hidradenitis suppurativa, again, that disease is progressive. It creates scars. There are sinus tracts and tunnels under the skin. These harbor a biofilm. They often need to be surgically excised. But if we get on this early with a biologic that can prevent the formation of this scarring, this fibrosis, these tunnels and tracts, then they're not going to need the surgery later. So I have another analogy here. This is like a train. I had a patient, and I made this analogy up on the spot for this patient and was pretty happy with it, so I bring it out from time to time. This patient does have psoriatic arthritis and just does not want to go on a biologic because he's afraid that it will suppress his immune system. In the meantime, he is becoming increasingly disabled from his psoriasis, psoriatic arthritis specifically. Now, luckily, it's still in those early stages, but I told him it's like he's on a slow-moving train. The train is moving towards a cliff. The train's going to go off the cliff no matter what. There's no brakes to the train. There's no conductor. Nobody's stopping this train. It's going off the cliff, and he's going with it unless he gets off the cliff, off the train. The train is going slow enough that he can jump off of it. Other people are jumping off, and every once in a while, somebody's jumping off and spraining their ankle, and that's painful, and he's seen that, and he doesn't want that to happen to him. So he's not jumping off because he doesn't want to take the chance, the off chance that he gets a sprained ankle, even though most patients are jumping off and doing just fine. Well, so psoriatic arthritis is like this in the sense that if he stays on the train, the damage that he's going to get is going to be way worse than that sprained ankle. If he jumps off the train, he's most likely to not get a sprained ankle, but even if he gets the sprained ankle, he's saving himself from going over the cliff. So it's important to share these analogies. It's important to understand them as providers so that we're availing our patients of these life-changing, disease-altering medications in time. And I already alluded to this, but sometimes adult patients just benefit from the convenience. They're going from twice daily dosing of topicals, which is day in, day out, to as few as 4 times a year. Our IL-23 inhibitors in the psoriasis space such as Skyrizi, are dosed every 3 months. Just one quick shot every 3 months, and in many cases, that prevents patients from having to use any topicals at all throughout the rest of the year because they're 100% controlled. Now, even if they're not 100% controlled, they may be 90% controlled with a flare here and there, or 80%. Whatever the case may be, they're using way less topicals, so there's a definite convenience factor there. It also reduces their visit burden, the burden on the healthcare system, their copays. You don't have to see them as often. I know you love to see them. And so when you do see them, it's a fun visit. They come in, they're happy, they're well controlled. And so those visits are pleasant, but they don't need to come in as often. And again, we talked about at the beginning the hero factor. You're the quarterback. As the primary care provider, you are in charge of their care. So you're the quarterback. And when you complete the game winning, life changing pass to a specialist, you're the hero. So who doesn't want to be a hero? So, what are the costs? Well, they are expensive medications, and I acknowledge that to patients sometimes so they understand why there's a little bit of paperwork and delay involved. But the truth is, these medications are free or almost free for almost everybody. If they're commercially insured, it's easy. There's copay assistance. I warn the patients, you might hear from the pharmacy that you owe $2,000 for the copay, but don't freak out. You just need to get the manufacturer to pay your copay, which they will do, and bring your copay down to a nominal amount. If the insurance says, no, we're not going to cover that at all, those commercial patients do get enrolled into what's called bridge programs where they get the medication for absolutely free. It's easy. The Medicaid, Medicare, and uninsured patients, a little bit more complicated, but there are patient assistance programs that come from third-party foundations. And these patients, as long as they meet or fall under certain income thresholds, then they too will get free medication. It's almost everyone who falls within one of these two paradigms and get the medication for free or almost free. If you think about it, our patients that are commercially insured, we know they're going to get it for free or almost free. If they're not commercially insured, they're either going to meet the income requirements, or they are they're going to be able to afford the copay. So very few patients fall in between the cracks there, and we just have to navigate that system, and we walk them through that. That's not anything that primary care needs to deal with, but our patients need to know that these medications are worth it and will help them get them. In terms of costs, these medications can reduce overall healthcare costs. If you think about all the comorbidities that go with excessive inflammation, we talked about some of these earlier, heart disease, dementia, the variety of things that occur when they're not sleeping that we refer to as well, the multiple doctor visits, the doctor shopping, the multiple medications that are just tried and failed and churned through. We can actually potentially reduce overall healthcare costs, but we can also save costs in terms of work absenteeism and presenteeism. If you're not familiar with the term, presenteeism occurs when patients are at work, but they're not really performing at their potential or at expectation because they're not feeling well. They're distracted. They're unable to work effectively. This also has an effect, a negative impact on their professional advancement. And that comes into play in terms of their personal costs as well as costs to the greater society. So you may have heard of biosimilars. These are sort of like generics, generic biologics, and they have come onto the market as less expensive alternatives to the originator molecules. They must demonstrate equivalent quality, safety, and efficacy. Clinical studies are not required, which helps bring the cost down. And currently, we have many TNF alpha inhibitor biosimilars available. So again, this is in the psoriasis space, and there's quite a number of them, and there are more coming in other disease spaces and other mechanisms of action. So, as a primary care provider, how do you counsel patients? You want to talk to them about treating the root cause from the inside rather than just putting a band aid on it. You want to talk about these being controlling their disease, not a cure of their disease. You want to let them know that they need to be patient. It can take 2 to 12 weeks to take effect, depending again on the medication, the disease state, and the severity of their disease. You also want to tell your patients to let us, as derm providers, know if there's any changes in their health. And with that, you've gotten the basics of biologics. I did include quite a number of references. I'll click through them slowly, so you can pause if you need to check them out. 24 in all. Thanks for tuning in to this special episode of Derm Drop for primary care providers. It was written and hosted by myself, David Sider, with production and distribution help by Jacob Gary. We hope that it's giving you a solid foundation in dermatology biologics so that you feel comfortable having those conversations with your patients and you know when to refer them to your dermatology colleagues so that when they return with their disease controlled, with full functioning and quality of life, that you are in fact their hero. If you have any questions or comments, feel free to message me at LinkedIn, linkedin.com/in/Dave-Seiter. That's Seiter. And stay tuned for more dermatology content on Derm Drop.